We are into the seventh session of the first day's conference, and I would request you to excuse me for the bad sore throat and cough that I am suffering from. And we'll be talking about hospital-acquired CNS infections in this topic. About hospital-acquired infection, the WHO estimates a 5.7 to 19.1% in low and middle-income countries, and the rate of incidence of hospital-acquired infection, which is much higher in ICUs. And the infection frequency is 42.7%, 42.7 episodes per thousand patient days. So, what is the impact or ramification of the hospital-acquired infection, which is longer hospital stays, increased cost, lost wages and employment, and morbidity, disability, and death. So the impact of the hospital-acquired infections is much higher than the primary disease that the patient suffers from. Well, so much so that the hospital-acquired CNS infection has a greater impact on the patient in terms of morbidity and mortality. And it can be defined as a new onset CNS infection, which was not present at the time of admission, usually associated with certain neurosurgical intervention or an external or internal CSF flow diversion. It can be defined as an infection of the leptomeninges acquired during hospitalization, particularly manifesting 48 hours after neurosurgical intervention or in presence of CSF flow diversion device. It is characterized by CSF pleocytosis, increase in the cell count, biochemical abnormalities like decrease in glucose and increase in protein, fever, change in mental or neurological status, and abnormal blood counts. Although the incidence of hospital-acquired CNS infection is different in different regions of the world, an overall estimate of incidence has been found to be 4 to 17%. Let's talk about certain devices or certain interventions that are associated with the increased CNS infections, one of which is CSF shunts. CSF shunts can be infected by colonization of device during surgery, or there can be retrograde infection from bowel perforation. There can be transcutaneous spread while aspirating CSF from the reservoir, and there can be hematogenous seeding. The other culprit that contributes a lot to hospital-acquired CNS infections is the EVD, the incidence of which is calculated from as 0 to 22%. In a meta-analysis, Mahesh Raman et al. Saw that the pooled incidence rate was 11.4 per thousand catheter days. The mean duration of EVD of less than 7 days had a pooled CSF infection rate of 19.6 per thousand catheter days, and those with mean duration of 7 to 10 days had a rate of 12.8, whereas the duration greater than 10 days had a rate of 8. That means the incidence of CNS infection came down as the number of days of the EVD increased, which is contrary to what we generally believe. So this indicates that there is an issue with the insertion. There's an issue with the insertion technique. So this is an insertion-related issue. Excuse me. Other factors that are associated with increased risk of infection associated with EVD is intraventricular or subarachnoid hemorrhage, cranial fractures with CSF leak, catheter irrigation, the frequency of catheter irrigation, craniotomy, duration of catheterization. This study showed that the extended catheter duration, usually exceeding more than 5 days, to be an important risk factor in subsequent infection, which is what we usually see. About antimicrobial impregnated catheters, with clindamycin, rifampicin, or minocycline rifampicin impregnated catheters show a lower rate of bacterial colonization and positive CSF culture compared to a standard catheter. There has been no difference in the antibiotic impregnated and silver impregnated catheters. And the cons is that there can be false negative cultures that may result that may be seen when a CSF sample is drawn through an antibiotic impregnated catheter. So, how do we prevent EVD associated meningitis or ventriculitis or CNS infections? And that is by adherence of infection control practices. Strict adherence of infection control practices, formation of insertion bundles, formation of maintenance bundles. If there exists infection control bundles for CLABSI, for UTI, for surgical site infection, then why should there not be infection control bundles for EVD, which should be strictly adhered to and which should be followed. We should not be flouted at any step. We should avoid irrigation, frequent irrigation, unless intraventricular drug administration is required. Maintenance of closed system and avoidance of open system is very, very important. Nurses should be trained to handle EVD. So each and every nurse who is handling EVD should know the importance that a patient who acquires a central nervous system infection from this EVD can actually be fatal. And we should also try to remove the EVD as soon as it is possible clinically, as soon as the patient or the indication is taken care of. Well, British Journal of Neurosurgery in 2020 had a retrospective prospective study, and they had pre and post bundle infection rates, calculated infections rate, CNS infection rates in EVDs, pre and post implementation of pre and post bundle of care for control of infection. The pre-bundle care infection rate was 27%, and the predominant factor associated with infection being the number of cerebrospinal fluid sampling episodes. Following introduction of the EVD bundle of care, the infection rate declined to 10%, which is statistically significant. Here is an example of an EVD placement bundle that can be used. You can design it yourself in your ICU. It should be aseptic, and it can be similar to a central venous system, central venous catheter insertion bundle, and that is all that is required. And more than after designing it, implementation and adherence, strict adherence to following it is quintessential. It's essential to prevent infections of the EVD. This is another example of how to maintain the EVDs, and so similarly, this can be designed in your own ICU. It can be based on your regular infection control practices, and your infection control team can help you out in designing such a bundle. Well, another example of how to sample the CSF in a sterile aseptic way and further prevention of infection. Sampling should be as minimum as possible, but when it is required, it has to be done in a very sterile and an aseptic manner. There are certain other infection control processes that need to be addressed. Just implementation of bundles is not enough. You have prepared your bundles, but you need to educate and re-educate your ICU nurses, ICU doctors, physiotherapists, how to handle the EVD, how to take CSF samples. CSF sampling should be done by doctors. about they should be trained and they should be trained and retrained about hand hygiene, which should be the focus on repeated hand hygiene practices. And they should also be trained about how to handle the EVD aseptically, and minimum handling of the EVD as much as possible. Avoid handling the EVD. Other neurosurgical interventions that can lead to a CNS infection, meningitis, or ventriculitis could be an intrathecal infusion pump like Baclofen, or maybe a subarachnoid lumbar CSF drainage system, which can give rise to a meningitis. The incidence of infection is higher with subcutaneous placement of infusion pumps compared to subfacial placement. And majority of the organisms seen is Staphylococcus aureus. GNB is rare. Deep brain stimulation hardware column can also get infected, and most of it is a gram-positive infection. Coming to head trauma, the risks of CNS infection increases if there are surgical interventions done. There's a CSF drain. There are perioperative steroids have been given. There is a CSF leak. There's a basilar skull fracture, and this is in order of the frequency. It's difficult in a traumatic brain injury. It's difficult to establish what is the cause of the infection. Both surgery and trauma can introduce infection into the central nervous system. Identification of the organism and sensitivity pattern would be more suggestive of the hospital-acquired infection. So whatever organism is isolated and its relative resistance can lead you to identify whether it is hospital acquired or an infection which has been acquired during the time of trauma. It should be treatment should be done as hospital acquired infections unless proven otherwise, or the evidence or the infection is less than 48 hours. Infection is seen less than 48 hours of hospital admission. It's a typical picture of the cribriform plate fracture, this basilar skull fracture, which leads to CSF anuria and can cause meningitis and CNS infections. Excuse me. So, what is ventriculitis? Ventriculitis is the inflammation of ependymal lining of cerebral ventricles, usually secondary to infection, usually device-related or a complication of trauma. How can you diagnose? We can diagnose with a decrease in fall in CSF sugar, increase in protein, pleocytosis with 50% or more of polymorphonuclear neutrophils, and a positive culture or a gram stain. A CSF lactate of more than 3.5 millimole per liter is highly suggestive. Procalcitonin more than 0.5 nanogram per ml is also suggestive. Lysosomal enzyme. These are helpful in making an early diagnosis. As soon as you have taken a sample of CSF, you can check it in the ABG machine and see the lactate. And if it is more than 3.5 millimole per liter, then obviously the chances of infections are very high. Again, a CSF IgG index of 0.75 or greater predicts unfavorable outcome. So what is this IgG index? It is basically CSF IgG by serum IgG and CSF albumin by serum albumin. The other diagnostic modalities are in units, ultrasound, which shows increased thickness, irregularities, and echogenicity of ependyma with echogenic debris in the ventricle. NCCT head can show that the dependent hyperdense ventricular debris is there, hydrocephalus, periventricular low density, as well as features of meningitis will be there. With contrast, the ependymal lining of the ventricle enhances homogeneously. And an MRI T1, T2 would show a ventricular debris hyperintense to CSF, most common finding, and FLAIR images are sensitive to subtle, periventricular hyperintense signals. So these are pictures, CT and MRI pictures showing ventricular debris and periventricular, leakage of CSF, which are signs or indicates, these are the ventricular debris you can see, and there is leakage of CSF in the periventricular area, which indicates active infection. The CDC and NHSN surveillance definition of healthcare associated ventriculitis or meningitis includes at least one of the following criteria. This was published in January 2015. Organism culture from CSF, at least two of the following symptoms with no other recognized cause in patients aged more than 1 year, fever more than 38 degrees centigrade, or headache, meningeal signs, cranial nerve signs, or at least two of the following symptoms with no other recognized cause in patients aged less than 1 year, fever more than 38 degrees, or hypothermia less than 36 degrees, apnea, bradycardia, irritability, and at least one of the following: increased white cells, elevated protein, decreased glucose CSF, organism seen in the gram stain in the CSF, organism cultured from blood, positive non-culture diagnostic laboratory test from CSF, blood or urine, and diagnostic single antibody titer, immunoglobulin M, or 4 increase in paired sera immunoglobulin G for organisms. Coming to the microbiological aspect of hospital-acquired CNS infections, a retrospective study published in the Journal of Hospital Infections in 2006 showed the data of nosocomial meningitis in a university hospital between 1993 and 2002. And it can be seen here clearly that initially there are more of coagulous negative staphylococcus. It was more common in hospital-acquired CNS infections, and later on, the scene has been changed in 2002 to more of gram-negative bacilli. Now, more and more gram-negative organisms, more MDR and XDR gram-negative organisms are seen to be the causative agents for hospital-acquired CNS infections. This is a table which shows organisms which are based on the pathogenesis, whether it's a neurophysical or ventricular lumbar catheter, penetrating trauma, and basilar skull fractures. In the following slides that are to come, we will discuss about the IDSA's recommendation, which was published in 2017. And first is the CSF findings that are that suggest hospital-acquired infection. Abnormalities in the cell count, glucose, and protein may not be a reliable indicator for if there is a high degree of suspicion or clinical suspicion of central nervous system infection or hospital-acquired central nervous system infection. The CSF may not be very suggestive of it. Excuse me. Normal CSF cell counts, glucose, proteins may not reliably exclude infection in patients with healthcare-associated ventriculitis and meningitis, and a negative CSF gram stain does not exclude the presence of infection, especially in patients who have received previous antimicrobial therapy. About CSF culture, if the culture is positive, it's a gold standard. If initially negative and clinical evidence of CNS infection persists, repeat culture after 10 days. If a CSF shunt or drain is removed in patients suspected of having infection, cultures of the shunt and the drain components are recommended. These are recommendations of IDSA. Blood culture should be done in case of a VA shunt where there is a suspicion of infection. Obtained cultures should be obtained before administration of antibiotics. So how would you differentiate a contamination or colonization and a CNS infection? The contamination is an isolated positive CSF culture or gram stain with normal CSF cell count and glucose protein concentrations and with lack of clinical symptoms suspicious of ventriculitis and meningitis. Colonization, on the other hand, is multiple positive CSF cultures of gram stain with normal CSF cell count and glucose protein concentrations, and with lack of clinical symptoms suspicious of ventriculitis or meningitis. Again, coming to the IDSA recommendations of some special tests, CSF special tests, lactate procalcitonin, as we have talked about, nucleic acid amplification tests of PCRs can be done, and detection of beta D glucan and galactomannan in CSF may be useful in diagnosis of fungal ventriculitis and meningitis. Imaging recommendations, CE-MRI brain is highly recommended to see if there is electromeningeal enhancement in patients with infected ventriculoperitoneal shunts, abdominal symptoms, example pain and tenderness. Ultrasound computed tomography of the abdomen is recommended to detect CSF loculations at the shunt terminus. Recommendations of empiric antibiotics in case of suspicion of hospital-acquired CNS infection. First is vancomycin plus an anti-pseudomonal beta-lactam such as cefprime, ceftazidime, or meropenem is recommended as empiric therapy for healthcare-associated ventriculitis and meningitis. The choice of empiric beta-lactam agents should be based on local in vitro susceptibility patterns. So your antibiogram is important. You need to have a communication with the microbiologist and the infection control team to form an antibiogram which will lead you to choose your antibiotic. If there is a reaction to beta-lactam antimicrobial agent, or in patients whom meropenem is contraindicated, for example, if the patient is having seizures, then astronam or ciprofloxacin is recommended for gram-negative coverage. Vancomycin is a time-sensitive drug. It has to be a minimum, MIC has to be maintained. A trough concentration should be maintained at 15 to 20 microgram per ml. So the duration of dosage and the frequency should be adjusted accordingly. What about specific antibiotics? If it is a methicillin sensitive Staphylococcus aureus, ampicillin or oxacillin is recommended. Whereas a methicillin resistant Staphylococcus aureus, vancomycin is the drug of choice. Alternative to vancomycin are linezolid, daptomycin, or cotrimoxazole. Devices associated with Staphylococcus which are sensitive to rifampin can be added along with vancomycin. In case of gram-negative bacilli susceptible to third generation cephalosporin, ceftriaxone, ceftazidime is recommended. And MDR pseudomonas, meropenem, or alternatives to meropenem or astronam quinolones. If it is an Acinetobacter, meropenem is the drug of choice. And if we isolate a pseudomonas or an Acinetobacter, which is an XDR, then intravenous plus intraventricular colistin or polymyxin should be used. Both meropenem and vancomycin are time-dependent drugs, so the duration of administration is important. A single dose of meropenem should be given at least over 3 hours, if not a continuous infusion. We calculate the total dose in a day. Suppose 6 grams, you are giving 2 grams 8 hourly. 6 grams, it can be given by continuous infusion over 24 hours. 6 grams of meropenem can be given over 24 hours in continuous infusion, which would be more beneficial. For the treatment of infection caused by fungus formed by Candida species based on in vitro susceptibility testing, liposomal amphob is often combined with 5-fluorocytosine is recommended. And for treatment infection caused by Aspergillus, voriconazole is the drug of choice. Intraventricular antimicrobials, which are what are the key points of intraventricular antimicrobials? is to consider, we have to consider giving intraventricular antimicrobials in poor responders to systemic therapy alone. When antimicrobial therapy is administered via ventricular drain, the drain should be clamped for 15 to 60 minutes to allow the agent to equilibrate with the throughout the CSF. The doses in interval of intraventricular antimicrobial therapy should be adjusted based on CSF antimicrobial concentration to 10 to 20 times the MIC, the causative microorganism, ventricular size, and the daily output of ventricular drain. So these are the recommended table shows recommended doses of antimicrobial agents administered by intraventricular route. Usually colistin 10 milligram, that's almost equal to 1.5 to 1.7 MIU. 1 MIU is equal to 80 milligrams. Sorry, 1 MIU is equal to 1 milligram is equal to 12,500 MIU. So 10 milligrams would be around 1.5 MIUs per day. The colistin is required. What are the preventive approaches that is recommended by IDSA? The peri-procedural prophylactic use of antimicrobial agents is strongly recommended. Prolonged antimicrobial prophylaxis is not recommended. Antimicrobial impregnated CSF shunts and CSF drain is recommended. Fixed interval exchange of EVDs is not recommended. And insertion and maintenance of care bundles for infection control is highly recommended. In traumatic brain injuries with CSF leak, for neurosurgical patients, perioperative antimicrobial agents are recommended. Basilar skull fracture and CSF leak, prophylactic antimicrobial agents are not recommended. In patients with basilar skull fractures and prolonged CSF leak more than 7 days, an attempt to repair the CSF leak is recommended. In patients with basilar skull fractures and CSF leak, pneumococcal vaccination is recommended. Coming to the key points, infection control bundles are to be prepared for insertion and maintenance of CSF drains, and they should be implemented. There should be strict adherence to these infection control processes, regular audits, education, and re-education about handling of CSF drains. The nurses should be trained, the IC doctors should be trained, they should be aware of the consequences of a central nervous system infection, particularly hospital-acquired central nervous system infection. Removal of CSF drain should be done as soon as possible, and peri-procedure or perioperative antibiotics should be used. There should be vigilance, early detection and CSF analysis on slightest doubt of a central nervous system infection. A CSF lactate and a procalcitonin value may be used for faster diagnosis and initiation of treatment. Thank you very much for bearing with me.